these lovely faces bright and early on a Monday. Well, here, bright and early on a Monday morning, but Monday nonetheless, wherever you are in the world. We are so excited to see you all today. We will be looking for a case presenter and two discussants to join us in the wonderful lukewarm seat that we all love and cherish. Just to introduce myself, I am Smitha Ganeshan. I'm a second year resident at UCSF and a CP Solvers team member. I'm finally on a rotation that allows me to be here, and so I have very much missed this community and excited to be back. I'm here with my good friend, Jack Penner.
Hey, good morning, everyone. Great to see you all today. Really excited to get to be back in the lukewarm seat and to get to facilitate and learn alongside Smitha and everyone else here. So yeah, thank you all so much for joining today.
Awesome. Well, while we are waiting for a case presenter and student discussants, Jack, do you want to take us through a reflection on yesterday's student VMR case?
Sure, I would be absolutely thrilled to. I will say, as I talk here, please do volunteer in the chat. There is always a letdown that happens when the reflection finishes and you look in the chat and there's no case volunteers or no volunteer case presenters yet. So please feel free as you listen to toss your name in to either present a case or join us in the lukewarm seat. But yesterday's case of on student VMR, I think was a really interesting one in that it started. I'm always a fan of cases that have a chief concern that starts with an organ system that's not related to what the final diagnosis is. So this was a case of a young gentleman who presented with diffuse generalized pruritus, which when I oftentimes hear that up front, the first type of disease process that comes to my brain is a dermatologic process because of itchy skin. But this one actually ended up localizing into the hepatobiliary system when the patient was found to have scleral icterus on exam, and then a markedly elevated bilirubin to 21 with a direct bilirubin of 6.4, and then some elevated liver enzymes, and then ultimately a liver biopsy that showed central lobular cholestasis with necrosis. The final diagnosis was actually drug-induced cholestatic hepatitis related to androgenic anabolic steroid use. I think that there was a couple of things that I found very interesting about this case. And the first one of them was sort of working through the journey of hyperbilirubinemia. And so this was a patient, again, their total bilirubin was in the low 20s with a direct bili of 6.4. And I think this is an interesting area to zero in on, because the patient had a prominent indirect hyperbilirubinemia. And I think we classically learn that the sort of branch point when looking at a patient with jaundice is asking, is it a direct bilirubinemia or an indirect bilirubinemia? Direct bilirubinemia is oftentimes localizing us to the hepatobiliary system, whether it's intrahepatic cholestasis or extrahepatic cholestasis, whereas an indirect hyperbilirubinemia usually takes us down the hemolysis pathway or potentially something like heart failure causing a congestive hepatopathy. And so in my own mind, oftentimes if I see a primary direct bilirubinemia, I think liver. If I see a primary indirect bilirubinemia, I think hemolysis. But there's one other tool that we can sort of add to our toolbox of how we think through a patient who has jaundice. And not only is it how much is direct, how much is indirect, but also the total height of the hyperbilirubinemia itself. Patients who hemolyze, it's quite rare for them to hemolyze up to a bilirubin into the high single digits, 7, 8, 9, 10. Oftentimes they're probably going to be around 3, 4, 5, maybe a T-bili of 6. But when you start getting into double-digit hyperbilirubinemia, it's pretty difficult for hemolysis to be the primary driver of that. And so I think in this case, it's an interesting example of the total peak of the patient's hyperbilirubinemia probably being the factor that can help us localize to the hepatobiliary tree, because there's so much more there's so much more bilirubin that can back up from the liver than there is bilirubin that can be produced as a result of a hemolytic process. So I guess that would be teaching point number one. Don't just use indirect and direct, but think about the total height as well when you're getting into the double digits of jaundice, thinking about a hepatobiliary cause independent of what the ratio is. And then the next question is, well, why was this patient having an indirect hyperbilirubinemia over direct? And I have not been able to find a good answer to this. I think there's probably a few hypotheses that are plausible, but it certainly is something that we can see, but just less often than the classic intrahepatic or extrahepatic cholestasis that can come with a direct bilirubinemia. And I think one plausible hypothesis is that the individual may have some underlying enzymatic deficiency, that in the setting of liver damage or liver injury, that enzyme's ability to conjugate bilirubin goes down. And so we get a backup of bilirubin within the liver. However, the enzyme production isn't just there to conjugate. The corollary that we see for this is something like Gilbert's disease, and some patients may not necessarily have, or this, when they have a liver injury, we may only see that enzyme doesn't work well. And then the other hypothesis is when there actually is hepatic cell necrosis and cell death and sort of diffuse liver injury, then the cells may not actually be, or then the hepatocyte enzyme function may just be deteriorated as a consequence of an acquired enzymatic deficiency from the liver damage. And so I'm not sure what's going on here, but this is now one of a handful of cases where I have seen this sort of pattern of direct liver cell injury causing this primary indirect bilirubinemia, but it's still localizing to the liver rather than to something like a hemolytic process. And then the other thing that I just wanted to highlight here is that the individual had an elevated hemoglobin of 17 and a hematocrit of 51. Normally, when we see acute liver injury or chronic liver disease, patients will be anemic, right? If somebody has an acute viral infection, oftentimes there will be an anemia of inflammation that will come with that. If somebody has autoimmune hepatitis, the autoimmune disease itself will oftentimes carry anemia with it. If somebody has acute liver failure and is quite critically ill, oftentimes we will see anemia come alongside that. But the combination of liver injury plus polycythemia or a high hemoglobin can narrow into a couple different things. Classically, what you might see is hereditary hemochromatosis, and I encourage you to check out Robbie's Twitter feed for a great illness script overview of this from last week. But then the other thing is that maybe there's something that's causing, or maybe there is a hormonal process that can be causing both liver injury and polycythemia, which was the case here. There is a long list of things that can cause polycythemia, but I think the list narrows a little bit when we think about polycythemia plus liver injury, and we can think about classically genetic causes like hemochromatosis, acquired causes like iron overload, or a toxin-mediated process like in this case, anabolic androgenic steroid use. So to summarize, I guess the three key points would be not all indirect bilirubinemia is coming from somewhere out of the liver. When you're getting into the double digits, the probability shifts back to a intrahepatic or extrahepatic cholestatic cause. Our key branch point there will be the right upper quadrant ultrasound. If you see biliary ductal dilation, it's probably extrahepatic. If you see normal bile ducts, it is probably an intrahepatic process like it was in this case. The second teaching point being that, again, the combination of jaundice and polycythemia, we can think about genetic causes, acquired causes like iron overload, or potentially exogenous steroid use, which can cause both liver injury and then also activate the bone marrow. So that's all I got. I'm curious if anybody else has things that they want to add in the chat, or if there are some case presenters and case discussants that we get to meet. Thank you, Martin.
Jack, that was a brilliant discussion, and I see a lot of excitement in coming through in the chat, sort of echoing a lot of these teaching points that you made. We do have a case presenter, Rebecca, who has graciously agreed to present a case to us. And then we have Gabriel, who is willing to step into the lukewarm seat with us and discuss a case. We are still hoping for one other student discussant. Again, if you've never discussed, this is a great way to learn and have a lot of fun. So please consider joining us. But maybe while we're waiting, we can have Rebecca unmute yourself and tell us a little bit about who you are, both inside the clinical learning environment and outside. And then Gabriel will have you go next as well.
Thanks, everyone. Hey, I'm Rebecca Berger. I am an attending hospitalist at Weill Cornell in New York City. I've loved getting to tune into VMR over the last couple of months, and I'm just so humbled every time how much I can learn from all of you guys, especially the students and the trainees. It makes me so jealous that I didn't have this community when I was in training, so I'm kind of living vicariously through all of you. So again, here in the hospital, I take care of patients when they're admitted to the hospital. I do some teaching and a lot of work in quality improvement and some kind of operations and patient flow work. And outside the hospital, mostly these days, just chasing around my 2-year-old who is fast. So that takes up most of my time.
Thank you so much for being here, Rebecca. It's great to see you. And it's always just, it's really nice to get to learn a little bit about people outside of. I feel like oftentimes we there is this like very clear clinician self that we oftentimes bring into these clinical problem solving cases. And I think one of my favorite parts about VMR every day is sort of the little pieces of who we all are outside of our clinical jobs that we get to see. So thank you for sharing that with us. Gabriel, could we maybe turn it over to you to introduce yourself, and hopefully hearing the fantastic introductions from you and Rebecca will inspire one more person to toss their hat in the ring today.
Hi everyone, my name is Gabriel. I'm very happy to be here today with you guys. I love all these VMR sessions. I learn a lot, and I know this will be a little challenging because I haven't done all my rotations yet. I'm a Peruvian second-year medical student and very motivated to be here today. So I hope you guys volunteer. I know it will be fun. Oh, I think Han has volunteered. Thanks, Han.
Han, welcome. We're so excited to have you. Please unmute yourself and introduce yourself.
Yeah, hello, I'm Han and I'm a medical intern from Vietnam. And now I just graduated from the medical university a couple months ago. So I'm happy to be here.
Han, we are absolutely thrilled to have you. It's great to see you. Thank you so much for volunteering to discuss today. I am very, very excited that you're going to be a part of this case. Han, maybe you and I can team up and we'll take the second and fourth aliquots today. And then Smitha and Gabrielle can take the first and the third aliquot. Does that sound okay?
Yes, Dr. Jack.
All right, sounds great. And then actually, before we maybe turn it over to the screen, Kirtan, since you are one of that, I'm sure many people here know you as a participant in VMR, but would also love to have you introduce yourself as you start to transition into this new role of having given teaching points last week and then also scribing today.
Sure. So I am a final year medical student from India, and I am from BJ Medical College. And I'm so excited to be here today. I just become a team member now. And I am so happy that actually lots of friends are there who can help me through my this session. And let's see how it goes.
Awesome. And then Priyanka, are you on teaching points today? Do you want to unmute and introduce yourself as well?
Hi everyone, I'm Priyanka. I'm a fourth year medical student at UCSF, currently in my last course of medical school. And graduation is this weekend, so it's pretty insane. And I'm really excited to be here. I haven't been able to make VMRs because of this course, which overlaps with the time, but I'm glad that this one started a bit earlier so I could hop on before my class.
Amazing. Well, Kirtan, do you want to take it away and share your screen? And Rebecca, we're really excited to learn from you.
Okay, you guys ready? Awesome. So the chief complaint is 4 months of fevers. So this is a 63-year-old man who, as I said, is presenting with fevers over the course of the last 4 months or so. His symptoms began in December of 2020 with night sweats and chills. At that point was having subjective fevers and progressive fatigue. These symptoms have kind of slowly, insidiously progressed over those last 4 months or so since they started. About 2 months into the illness, he went to go see his primary care doctor, who did what he said was some routine blood work and an echocardiogram, which were both reportedly normal, according to the patient, but his symptoms persisted. His only other localizing symptom has been pain in his left knee. He did have a history of a replacement of that left knee in December of 2019, so about a year before the symptoms started. He can't identify exactly when the knee pain started, but he started to just notice kind of a nagging pain in that left knee, which has been constant but worse with exertion and improved with acetaminophen. He has not noticed any redness or swelling of that knee. So on the day he decided to come into the emergency room, it was for 2 things. The first was that he finally bought a thermometer after 4 months of symptoms, measured a temperature of 103.7 Fahrenheit. So that's 41, 42, something. No, sorry, 40. Someone do the math for me. The second was that he had new onset of nausea and epigastric pain, which were bothersome to him, prompting presentation. What do you think? I have some review of systems. Do you guys want to pause there, or do you want to do some review of systems?
We can pause there, whatever you think would be great. What a rich aliquot. Thank you so much, Rebecca. I'm already so excited for this case. Gabrielle, what stands out to you here when you hear this sort of history of 4 months of fever? How do you start to think about that?
Yes, so we have a gentleman coming to the hospital because of a fever that is getting subacute. And first, when I think about subacute, I want to know who the patient is, what is the context of the patient, and maybe also the conditions and the epidemiology. Because here in Peru, when thinking about subacute fever and night sweats and chills, the first thing we think about is TB, and it can be sometimes really hard to make a diagnosis of TB because it can have a lot of extrapulmonary manifestations. So that's one thing I will keep in mind. But then the history that the patient had a knee replacement in December of 2020 made me think of a complication maybe of the surgery. And I think Rebecca mentioned it, that the patient had an echocardiogram, because I will also have thought about maybe a possibility of endocarditis related to that surgery. For example, some organisms are staph epidermidis, that is related to that subacute endocarditis sometimes, but that the exam was negative. So maybe we should reevaluate that probability. I will not rule out yet a possibility of endocarditis. And also, I love the mnemotechnic about fever. I met infection, malignancy, autoimmune, drugs, endocrine. I think about that. Maybe sometimes we should keep the infection in our background. Malignancy too, especially sometimes of hematological malignancy, he's in the age of getting those. and maybe I will investigate more about the drug's history. I think he doesn't had consumed any of my concerning, but acetaminophen. In case of endocrine, I'm not seeing any signs of, for example, hyperthyroidism that is sometimes related to fever. And then if we cannot get to the cause, we should think about fever of unknown origin, which is another word from autoimmune disorders, like, for example, lupus. And I think because it's a left knee pain, we should keep lupus in a differential, although it's very like weird to have a. Oh, I'm sorry. I think I got out of the Zoom. Can you guys hear me?
We can hear you perfectly now.
Oh, I was mentioning about the part that the fever of unknown origin, because the patient have 4 months of fever, that if fever of unknown origin is another word. And for example, in that differential, there are some autoimmune disorders, like for example, lupus, that can sometimes present as this non-specific fever and chills, but it will be like non-classic for a 60-year patient with a male presenting with lupus and just with a left knee pain. So that was like what I was thinking.
Gabrielle, that was masterful. Such an amazing discussion. And I really have nothing to add. I will just highlight 3 things that I heard you do that were so brilliant. And the first was translating fever into inflammation. Right off the bat, you sort of heard fever, the night sweats, the chills, and you're starting to think about this person as inflamed. And so coming back to that, I made mnemonic. And then from there, you layered on the time course. So the clinical syndrome multiplied by the time course is queen. And here you said, well, it's kind of weird that the time course is 4 months long because many of our infections usually take their course on the order of days to weeks. And so when we think about FUO or fever of unknown origin, the definition of that is fever that persists longer than 3 weeks. And the reason that's the definition is that, most bacterial infections take their time course over the course of 3 weeks. So after that 3-week mark, we're starting to get into the world of, either this is infection that is going longer than the typical course of the infection that we would expect, or it's an infection that's slightly more indolent. So you mentioned tuberculosis as potentially one of those types of infections. Or we're starting to get into this world of things that start to manifest fever more chronically. And so the things within the I made mnemonic that you pointed out that raise up in our differential are things like malignancy, usually more prominently liquid cancers as opposed to solid cancers. Things like autoimmune diseases, you mentioned lupus as one of them. Certain medications, so that will be something that we will be looking for. And then endocrinopathy like hyperthyroidism. And one of the gaps in my own knowledge is thinking about the severity or the how high the fever is. Sometimes like greater than 104, or even sometimes 103. I start to think about some of those drug-related fevers, but I think all of those things that we talked about are still at play. And then the third thing that I wanted to highlight that you did so well was thinking about, well, how is the background going to change how we think about fever in this particular patient? And one of the things that you highlighted was the knee replacement that this patient has undergone. So how does that modify our differential? And it's really the only localizing signal that we have here. Potentially someone with hardware in their knee is perhaps more at risk for some sort of infection in that knee. And even though we're not sort of seeing sequelae of that, the redness and swelling, certainly you can have kind of more indolent infections that sort of brew in the knee, particularly in hardware, and can be quite sticky, that maybe would show up as a more chronic type fever. So really, to summarize, I have nothing to add. You called out essentially everything the points that I wanted to make, which is when we see fever, we should translate that into inflammation. We layer on the time course, in this case, a chronic fever. We start to think about things other than infection, but keep in the back of our mind that this could be sort of an atypical natural history of a typical infection or an atypical bug. And the third thing is really thinking about how does the background change how we think about fever. And in this case, the presence of hardware in this patient kind of rises up in the back of my mind, but really anything is possible at this point in the case. We're really undifferentiated. And I just want to congratulate you on really, really naming all of the things that, that we should be thinking about here. I'll turn it back to you, Rebecca.
Yes, can I add something?
Of course,
so Rebecca mentioned that there's no swelling or a redness on the knee, but sometimes the knee can be a deep joint. So maybe there is some inflammation that we cannot see on the physical exam, like in the shoulder. So arthrocentesis, as MK said in the chat, would be very nice to have.
I love that, Gabrielle. That's such a good point. And I want to also make the point that Priyanka has very helpfully highlighted what is red. And I didn't talk at all about nausea and epigastric pain. We're going to track that in the background. It's hard to know with nausea and abdominal pain. Is that going to be signal? Is that going to be noise? But it's something else that, that we're tucking away.
Awesome. I can't wait to work with you guys all as colleagues in the future. This is so great. I'm going to start next with the remainder of the review of systems and then move on to his past medical history, et cetera. So throughout the course of this illness, he notes that his appetite has remained good. He thinks he's lost maybe a few pounds, but he hasn't checked his weight, and he has not had to buy new pants since the onset of his illness. He has had no other, as I mentioned, localizing symptoms, so no URI symptoms, no cough, shortness of breath, chest pain, changes in his bowel habits, no neurologic symptoms. He has not noted any joint involvement besides that left knee that I mentioned, and has had no rashes or any other rheumatologic symptoms. No recent dental work or dental infections. He is fully vaccinated against COVID and has had no known COVID exposures. No history of homelessness or incarceration, no TB exposures. And that's kind of the relevant review of systems. I'll move on now to his past medical history. So in addition to the left knee replacement that I mentioned in 2019, he also has a history of aortic regurgitation, severe, for which he had a bioprosthetic aortic valve replacement in 2018. He also has hypertension and prostatic hypertrophy, neither of which he's on medications for. I'll pause so you guys can catch up on the, sorry. His only medication is 81 milligrams of aspirin daily. He takes some vitamins and supplements, no other prescribed medications. Family history, not too remarkable. His father had colon cancer in his 60s, no history of lymphoma or any other malignancies, no history of rheumatologic or autoimmune disease. And then in terms of his social history, so he lives in Brooklyn. He runs a motorcycle repair shop for work, so he works outside, but notes that he doesn't hike or spend any time in the woods or in any fields or anything like that. He was born in the US, has traveled internationally, but has never lived outside the US. As I mentioned before, no homelessness, incarceration, or no known TB exposures. He does not have any pets. He has not been to any farms recently. He is also not an IV drug user. And I think that is the relevant history. I'll pause again there unless somebody else has questions.
Rebecca, can I just clarify one question about the knee replacement was in December 2020, and then the fever started how long after that?
Sorry, the knee was in 2019. The aortic valve was in 2018. The knee was in 2019. The symptoms started in 2020. So each of them were about a year apart.
Great, thank you so much.
Thanks, Jack.
All right, Han, feel free to take it away in terms of how the information that we just received here is informing your thinking about the case.
Yeah, Thank you for Dr. Rebecca for the second eloquent. I agree to Dr. Samantha and Gabriel on the thing they discussion about above when we think about some atypical infection, autoimmune disease, malignancy, especially for the fever, for the chronic fever. The thing that in the first eloquent I have confused is the nausea and gastric pain. I think I wonder if that is related to the GI tract or not. And the next eloquent that Dr. Rebecca profiled, that is the patient have no bowel disturbance. That make me think that that make me far away from the organ GI tract infection in this patient. Move to the past medical history. The patient have the procedure in the aortic valves. Made me think of the case that Kira presented before, in which patient infected the myobacterium strain that affected the bioprosthetic valves. I don't remember exactly the name of the strain of this patient. To the medication, I don't think the medications have create the fevers of the patient. The family history with colon cancer maybe change a little bit of diagnosis. Maybe this patient is at risk of the malignancy in some ways. For the social history, she owns a motorcycle repair shop. I think there's something bacterial infection or something environmental exposure to the patient that may can cause his infection. And to summarize my discussions now, I think that I continue to prioritize the infection of the patient, especially with atypical infection, and he is at risk of bioprosthetic aortic valves, and furthermore, it will the infection maybe will connect with the knee replacement of the patient. The second different diagnosis of me is a malignancy because the patient has the risk of the colon, has a family history of the colon cancer, and I wait for the physical examination to examine about the vital signs of the patient, the extremistry to investigate his need, and especially the cardiac vascular examination. Is there any murmurs or that point me to the heart valve injury? That is end my discussion.
Absolutely fantastic job, Han. I have nothing to add to your analysis of the case. I think you captured all of the key elements and the key pieces of data perfectly, as well as the tensions that we're currently navigating in this case. Which, just to summarize what you said, is that we have to prioritize infection based on solely the base rate of disease, but also the morbidity of undiagnosed infection. And our first task when we have fever and a suspicion for infection is to localize it. And there's sort of three sites that we could potentially localize as the source or as the complication of the ongoing infection. We have the knee joint, the bioprosthetic valve as being another place where there's hardware, and then also the gastrointestinal tract. And in parallel, to evaluating for infection, we also have to consider a non-infectious source, which you're right, in an elderly gentleman who has a family history of underlying malignancy, thinking about a malignancy as the potential underlying etiology. And I think whenever we're stuck reasoning through these types of, I shouldn't say stuck, whenever we're tasked with reasoning through these types of cases, really to work these two things in parallel, I think I always try to remind myself that we need evidence to accumulate that convinces us that this patient does not have an underlying infection before we start to move on into heavily considering the non-infectious causes. And so in this case, what type of data might that be? Well, it would be consistently negative blood cultures, because if the patient did have a prosthetic joint infection, they could certainly become bacteremic. It would probably be another just confirming that there was that there is indeed a normal echocardiogram. Rebecca gave us the helpful information that there was a normal echo in the past, but as symptoms have been ongoing, the pathology could have changed. The patient may have had an infection somewhere else that has now spread to the heart valve, or they may have had an infection on the heart valve the whole time that has now progressed to the point where it has become echocardiographically visible. And so in the same way that patient symptoms will evolve over space and time, the results of diagnostic tests can also evolve over space and time. And so thinking about at least potentially evaluating the heart valves, again, depending on whether or not we have blood cultures. But if the infectious workup is negative, we don't see anything in the stomach, the knee imaging looks like it's normal, we don't have signs of a bloodstream infection, and the heart valve seems to be negative, then we can pivot into thinking about the malignancy category. And I think that you walked through that sort of cognitive process absolutely brilliantly, Han. So I will stop there and turn it back over to Rebecca for the next aliquot.
Thanks, Al. Just to add a few clarifications from the chat, he actually conveniently happened to have a colonoscopy like 2 or 3 weeks before the hospitalization for routine surveillance that he told us was normal. And then somebody asked why his knee was replaced. He had osteoarthritis, kind of wear and tear arthritis of that left knee. And I think those were, we don't know what the kind of etiology was of his aortic regurgitation. He wasn't known to have any kind of childhood cardiac diseases or anything like that. And he had AR, so it was not a bicuspid valve. No history of endocarditis in the past. Okay, so his physical exam, when I saw him, he was febrile to 38.3. His heart rate was 93. Blood pressure was 112 over 83. His respiratory rate was 16, and his O2 sat was 95% on room air. He overall did not look chronically ill or cachectic. I saw him around 3 a.m., so he looked tired, but otherwise, again, no evidence of kind of chronic illness. His HENT exam was notable for some poor dentition, but no kind of focal tenderness over his gums or his jaw or any other signs of active dental infection. His cardiovascular exam, he had a crescendo decrescendo systolic murmur, heard best at the base of the heart. His lungs were clear. His abdominal exam was notable for a mild epigastric tenderness to palpation. No peritoneal signs, no rebound guarding, shaker tap tenderness. No hepatomegaly that I noted on his abdominal exam. His neurological exam was unremarkable. He was oriented, no focal deficits. And then his extremity exam, he had no splinter hemorrhages or any other peripheral stigmata of endocarditis. His left knee had the well-healed surgical scar, no effusion. He had full range of motion, and he noted some minimal pain on passive and active range of motion, but no erythema or effusion, nothing that limited his range of motion. I'll give you some of his basic labs and then we can pause. So his white blood cell count was normal at 8.8 with 71% neutrophils. His hemoglobin was 10.4, a little bit low. His platelets were 154. His basic metabolic panel was completely normal. Albumin was a bit low at 3.1. His LFTs were normal. He had an ESR of 49, a CRP that was elevated at 6.6, and a normal rheumatoid factor. He had normal x-rays of his chest and his left knee. And his EKG was essentially normal. He had a normal PR interval, a normal QTC. His R wave progression was a little bit borderline delayed. It wasn't clear whether that was due to lead placement, and we had no priors for comparison. I can drop, if you guys need to catch up on I just dropped his labs into the chat if you guys need anything.
And was his BMP normal? I think I missed that.
Yes, his BMP was completely normal.
Great. Gabriel, any clarifying questions?
Rebecca, I didn't hear you so well about that. I wanted to make sure that the patient didn't have a bicuspid aortic valve.
He was not known to have a bicuspid valve. He said he was just found to have the leaky aortic valve a few years ago, and it was severe, so it was replaced. We don't know much else about the etiology of that.
Gabriel, it's always hard to get that first aliquot that's full of data, and you're sort of sifting through like we would be in real life, thinking about what do I really anchor on here, and what stands out to you, and how are you thinking about this exam and some of this prelim data as it relates to the last aliquots?
Mm-hmm. Yes, we have this patient that just came with fever and signs of inflammation, and the physical exam, it will be very helpful to help us to localize where the fever is coming from, where is the point of the fever. But in the physical exam, we are not getting so much signs of any pulmonary distress, any neurological distress, any abdominal sign distress. So we are not getting any signs that help us to localize the fever yet, but it can be sometimes helpful to say, okay, maybe the patient does not have any pulmonary etiology that is related to the fever, or the fever is not related to any abdominal abnormalities or GI abnormalities. I will be very cautious to dealing with the cardiovascular system, despite we are not seeing any signs of endocarditis stigmata. The biprostatic aortic valve is predisposed to have endocarditis because there is a previous lesion there. So bacteria could adhere there and provoke insidious endocarditis, and that could be sometimes culture negative. Some of the agents that can cause culture negative endocarditis are, for example, Legionella pneumophila, or, for example, Mycoplasma pneumoniae. But sometimes these agents present with respiratory signs. But in these patients, we can see those. Another agent could be Chlamydia trachomatis. I will ask about sexual history because sometimes Chlamydia trachomatis can cause reactive arthritis, and it can match with a left knee pain. But Rebecca said that the knee pain was related to the osteoarthritis, and that could be the etiology, and just left knee pain could be like noise in this case. So we have to be very cautious and open to that idea. And I was thinking about in case of the background of the patient that have the biprostatic valve. Sometimes when we have a thrombi, we can have like this fever and signs of inflammation, but the time of the clinical course does not match with me because sometimes it could be kind of acute, not like 4 months. And in case we were thinking about any thromboembolism etiology, I think we will most likely have any signs of respiratory distress, like for example tachypnea or saturation, but in this patient there is no any respiratory signs. So in case of the lab, I see a 71 polymorph. So maybe there is some bacteria and infection and that lab make us consider more the infection background or the framework. For now, I don't know what to do with the anemia. Sometimes when we have like a patient with microcytic anemia, we're having to focalize that too. One of the most common places when we search for it is the gastrointestinal system. And if the patient has a father with colon cancer, but the colonoscopy was normal, so that will be a little less likely, but we have to consider it. I don't know how much it will change our decision. And the albumin was low, and the ESR and the CRP are high as we were expected. In case of the AKG, that we have narrow QRS, delayed airway progression, I'm not very familiar with those AKG findings, but maybe the narrow QRS complex. Usually when I evaluate the QRS, I don't see if it's narrow, I see if it's broad. So I don't think if that finding will change our decision when we are investigating the etiology. The delayed airway progression, sorry, I will have to say I don't know what to make with that. I'm not very familiar with that finding. But yeah, finally, I don't yet I can't find any foci of the fever, but I will try to search more about a culture negative endocarditis or maybe a reactive arthritis, but I don't see any signs of urethritis or GI signs. So
Gabrielle, another masterful discussion. And again, you're leaving me very little to discuss. And so I will just highlight some of the things that I thought you did incredibly well, which is, how does this exam and these labs change things for us? I'm not sure it changes things that much from what Han and Jack left us with, which is we know this patient is inflamed, and our job is to try to look for a source of infection, and we are still seeing the same three sources that are rising to the top, which is 1, the knee, 2, the abdominal pain, and 3, the aortic valve. And we are hunting for these clues of, well, where might the answer lie on the exam? And one thing that stood out to me, just like you said, was this crescendo, decrescendo systolic murmur. And oftentimes once we have a valve replacement, the goal is to really fix that aortic regurgitation. In this case, we're seeing a systolic murmur, so it's not as consistent with the diastolic murmur that you might expect in aortic regurgitation. But certainly, it's hard to distinguish diastolic murmur. So the fact that there is a prominent murmur there is something that I'm taking note of, and something that, just as you said, may raise our index of suspicion for potentially a possible endocarditis. And in this case, we haven't gotten blood cultures yet, but just the time course of the fever may prioritize a more subacute bacterial endocarditis. And you talked about some of those organisms, like classically the Haysick organisms, which are often oral flora that can lead to a more indolent endocarditis. So that's sort of one thing that my mind is tracking here, but I totally agree with you. The only other sort of clinical reasoning point that kind of stood out to me was to be aware of normal vital signs and normal labs. So in this case, we know that the patient has a history of hypertension, not on any medication. So the fact that the patient's blood pressure is normal here, you know, we'll sort of see what the trend is over time, but it always raises my suspicion when I see someone who has a history of hypertension. Sometimes that's a chart diagnosis, but who comes in with normal blood pressures. It raises my suspicion of whether for this patient, this is actually a lower blood pressure than the patient usually lives with. And so that's sort of one thing that I'm tracking. And then in terms of the data, I agree with you here. The lack of leukocytosis doesn't necessarily mean that there isn't an infection. And with the anemia, it's sort of hard to know. You know, we know that this patient is inflamed and has been inflamed for some time. So is this just an anemia of chronic disease? You know, if we saw anemia plus thrombocytopenia, then we might wonder, you know, is there shearing of the red blood cells and the platelets across a valve where there is a vegetation leading to a MAHA type picture? But the hemoglobin alone, it's again sort of hard to know what to make of that. And then with the elevated inflammatory markers, again, we know the patient is inflamed, and our job is to find the source of inflammation. The point around the narrow QRS, I also don't really know what to make of that. Is that just like a overly excited His-Purkinje bundle system that's really, you know, really very quickly translating that electrical impulse? Maybe, but again, I agree with you. I usually sort of worry when that QRS widens. In terms of where do we go from here, I think we definitely need blood cultures to, just as Jack and Han said, to know, like, are we dealing with bacteremia here, and sort of these different signals that we're getting could be metastatic foci of infection. And then I'd want to know, you know, the immune status of this patient. So making sure that we have an up-to-date HIV. And then again, I know the patient has had a prior echo, but when our index of suspicion is so high, one test may not be alone to bring the pretest probability down low enough that we feel good about making sure that that's not a possibility. And then the other thing is that the aortic valve itself is very well evaluated on a transthoracic echocardiogram in most cases, but not always. And so if you're not happy with those images, getting a TEE will always get you better images. Usually we say that the mitral valve is often not fully evaluated and can't fully be exonerated on a transthoracic echo. But if you don't get great images, particularly with a prosthetic valve, I think getting additional testing with a TEE may be warranted here. So I'll pause there and hand it back over to you, Rebecca.
Guys, I did not mean to throw you off with that narrow QRS. It was just meant to be normal, meaning not wide, not widened.
I love
no
that.
conduction abnormalities. There's nothing, as far as I know, that causes a pathologically narrowed QRS. So I apologize. That's the way I write my EKGs in my notes, so that it's like my checklist that I haven't missed looking at anything.
Ooh, I'm gonna have to. I love that, Pearl.
In the future, maybe I'll just have to write normal QRS instead of narrow, so nobody else gets confused. Okay, so we did send off blood cultures, 3 sets of blood cultures, so 6 bottles total, which as of hospital day 3 remained negative. He did have an aspiration of that left knee. It was a pretty bloody tap. There were 23,000 red blood cells, 6,900 white blood cells, of which 89% were neutrophils. The gram stain was negative and cultures were pending. And then for workup of this abdominal pain, he had a CT abdomen, which showed a large geographical hypodense region in the mid to inferior spleen, suggesting a possible splenic infarct. But they also commented that an infiltrative process like lymphoma or granulomatous disease like sarcoid was possible, but less likely. They said that a PET CT could further evaluate if necessary. And then the radiologist also noted some sub-centimeter hypodense foci within the liver that were too small to characterize. I can put that read in the chat if that's helpful, guys. That's what you got is plenty. I'm gonna pause there.
All right, some meaty new data here that has come up. Han, I would love to hear what you're thinking.
Yes, The first thing in the next quote is a negative blood culture. I sorry that I don't remember all the agent that cause uh, negative blood culture. I just remember some bacteriola that relate to the cast when the patient exposed with the cast. Uh, there are some like Coxiella or uh, uh, Tropherima or Legionella that may cause a chronic manifestation if the patient have a cardiac failure. Um, the next thing that is the the left knee aspirate which show me that there's some infection in the knees of the patient. When the knee of the infection, I think the most dangerous agent of the knee infection is gonorrhea, when the patient are in the immunocompresses and have some sexual exposure, which not have uh, in this patient. The thing that is so surprising me is that the hypoechoic region in the spleen and liver. I don't know how to interpret these findings. I just know there may be a bacterial spread in the patient or something vasculititis in the patient, which can cause which spreads more in the spleen and liver, and maybe the spleen and liver injury may explain some GI GI symptom and GI physical examination in this patient. In the ECG, that I wonder about the delay of wave progression. When I know there's some myocardial injury in the patient, and the thing that I wonder any injury in the heart, that may be any myocardial injury or any signs of the heart failure in this patient. And this end of my discussion.
That was absolutely fantastic. Again, I think I am right there with you in terms of your analysis of the data that we got so far, which really kind of focus on, or I guess I would say that the data that we have, as you were saying, increases our probability of two potential processes here. One is it actually I shouldn't say it increases the probability. The synovial fluid analysis prevents us from decreasing meaningfully the probability of a prosthetic joint infection. And then the finding of the splenic infarct, I think, increases the probability of there potentially being an underlying bacteremic process, and specifically endocarditis in this patient. And I say endocarditis for two reasons. One is the sort of slow, smoldering, indolent course of fevers, but then also splenic involvement. And I don't know the answer to this question. I just know that I just know of it as an association, which is that for some reason, bacteremia overall very rarely tends to end up in the spleen. Endocarditis, as the underlying cause of bacteremia, very often does end up in the spleen, either in the form of a splenic infarct or a splenic abscess. And I don't know why that association exists. I have oftentimes wondered if it's simply just the duration of bacteremia that can happen in patients with endocarditis. Eventually, you might get something that winds up in the spleen, or if it's related to the fact that bacteremia from endocarditis oftentimes has emboli that can make their way to these end organs in ways that are different from when we just have bacteria growing in our bloodstream. But I would say, to start briefly with the synovial fluid analysis, there's really two numbers that are worth remembering when you're thinking about prosthetic joint infections, and those are 10,000 and 3,000. In an early prosthetic joint infection, so sort of in the initial weeks to months after the implant has been placed, when the synovial fluid analysis has a white blood cell count less than 10,000, that decreases the probability of there being a prosthetic joint infection. But as we talked about earlier in this case, when we have, for example, patients who have a slower, more indolent infectious course, the clinical manifestations and the degree of synovial fluid inflammation will oftentimes be lower. And so when you're dealing with a late prosthetic joint infection, which in this patient we are because it's a year plus out from the implant, when the synovial fluid white blood cell count is less than 3,000, it decreases the probability of a PJI. And so in this patient where we came in with a clinical syndrome compatible with a prosthetic joint infection, then have a synovial fluid analysis that continues to support that hypothesis, I think the concern here continues to be that we're dealing with some sort of infectious process within the prosthetic joint. And then the question is, how can we relate that to the two other symptoms that we had? One of them being the patient's gastrointestinal tract, and then the other one being this splenic infarct, which I am similar to you, Han, and to many of the people in the chat, wondering, is there potentially endocarditis happening? And I think that there's a couple ways that we could get there. One is that prosthetic valve endocarditis was the initial insult, and bacteria made their way into the prosthetic knee joint. And then the other would be the reverse, is that maybe we're dealing with a PJI. The patient has been bacteremic for some time, and that bacteria ended up seeding onto the heart valve. And somewhere along the way, some sort of embolic phenomena also may have gotten into the spleen. And then the last thing here is, how do we relate the nausea and vomiting into this? And I think that still is very much unknown to me. I think there could be one very elegant way if we're thinking about from a microbiologic standpoint, potentially something like a enteric streptococcal species, like Strep bovis, if we're thinking about the colon cancer here, or an enterococcus species. Patients who have GI pathology may be at increased risk for bacteremia from those types of pathogens that can then make their way to the valves. So maybe there's a GI process that led to, for example, an enterococcal bloodstream infection that made its way to the heart valve and to the prosthetic joints. And the reason I say enterococcus is because that is a species that can both cause these sort of indolent PJIs and prosthetic valve endocarditis, owing to the fact that it's just an organism that can be sort of commonly implicated in those disease processes. But that is probably too big of a stretch in terms of saying that with any degree of certainty. It's really more of just a hypothesis. But I think really, if we're thinking about how do we walk this case forward, waiting to see if those blood cultures grow anything, because 3 days is long-ish, but not long enough to say it's definitively negative blood cultures. And then thinking about, do we need to explore the heart valve further with something like a TTE or a TEE? And then do we need to explore this prosthetic joint with an operation to actually send cultures from the joint space itself or from the tissue surrounding it? But I think that sort of the overall summary here is that I suspect, I think we have mounting information that there's a prosthetic joint infection, some mounting information that maybe that there has maybe been bacteremia with the splenic infarct, and it would certainly be plausible that that bacteremia could either be leading to or coming from a prosthetic valve infection. Then I will be very excited to hear what the organism potentially is. But yeah, I would. That's, I think, it feels as far as we can reasonably take the case so far. And I'm really looking forward to the next piece of information.
You guys are awesome. So to kind of round out the case and give you guys some information, so a CT chest that was done at the same time as the abdomen, but I decided not to tell you until now, actually showed that the bioprosthetic aortic valve had some nodular thickening on it, for which they recommended an echocardiogram. So the transthoracic echocardiogram showed normal LV size and function, mildly reduced EF, about 45%, moderate aortic stenosis, and most notably a poorly visualized hypermobile echo density on the ventricular aspect of the aortic valve, which appeared to be consistent with a vegetation. That was confirmed on follow-up TEE, done mostly because that they just didn't get a good visualization on the echo. So based on those findings, he was started on vanc and ceftriaxone, and then finally on hospital day 4, those blood cultures from admission had positive gram stain for GNRs, which cleared after a few days. And then finally, just yesterday on hospital day 8 or 9, those GNRs speciated as Cardiobacterium hominis, which is the C in HASEC organisms. So can I give you guys just like 1 or 2 things I learned from this case and then let you wrap up?
Please.
Okay, so one thing that my colleague, I admitted this patient on a night shift, and my colleague who came in the next morning, at which point the CT chest and abdomen that I had ordered had already been done, actually noted that he met definitive Duke's criteria for endocarditis even before the blood cultures were positive. And that was basically because of the evidence of endocardial involvement. So if you call those CT findings, and then obviously the follow-up echo being a major criteria for Duke's, and then his minor criteria being heart condition, his fever, and the splenic infarct. That's kind of one of the biggest teaching points for me. I feel like I always wait for the blood cultures to be positive, but you can meet definitive criteria for endocarditis without them. Another thing that I learned from this case, as you all mentioned, was the lower cutoffs for prostatic joint infection white blood cell count. And just to give you guys some clinical follow-up, he is scheduled, I think, tomorrow for a redo AVR based on the size of his vegetation and the fact that they tend to not clear from prostatic joints, from prostatic valves. The orthopedic surgeons have decided not to do a washout or a replacement of his knee, mostly because of the relatively minimal clinical symptoms and the lack of notable exam findings. The main reason to perform joint washout for a patient like this would be for joint function, which he hasn't really lost. So yeah, I think for me, a lot of the learning was around those 2 points that I mentioned, the lower cut points for prostatic joint infection, as well as the fact that you can meet Duke's criteria without having positive blood cultures. One more thing. Sorry, yeah. One more thing I wanted to add about the nausea and the epigastric pain. So the day after admission, his pain kind of migrated into the left upper quadrant and became more focal and tender and kind of pleuritic. So my colleague and I were hypothesizing that maybe this is kind of a similar referred pain phenomenon that happens when patients have endocarditis, have appendicitis, where the initial pain he had was kind of this referred pain, and then it became more kind of focal and visceral. That was kind of our best guess because the nausea disappeared and this kind of focal left upper quadrant pain started right after.
Wow, what a magnificent case. And thank you for all of those amazing teaching pearls as well. I think that's super interesting to think about endocarditis and meeting those criteria even before you're waiting on the blood cultures, which can take days, as Jack mentioned, to really feel like they are definitively negative. Han and Gabrielle and Jack, any final reflections on the case? And then I will just say I have clinic this morning, and so I will need to hop off soon, but it has been such a joy to learn with you all.
Yes, thank you, Rebecca, so much for walking us through with your clinical reasoning throughout this case. I really enjoyed it. I would like to reflect some of the I had an endocarditis lecture last year, and one part that I came with me with that lecture is that sometimes when we see systemic emboli because of endocarditis leading to a splenic infarct, sometimes the patient can be asymptomatic. In fact, 40 of these patients with splenic infarct can be asymptomatic. So the CT findings and the background of this patient was very helpful to make the definitive diagnosis, as you said, of infective endocarditis. And here in Peru, the cultures, the majority of them are negative because the patients walk through different hospitals and the doctors can find the cause, they give antibiotics. And when they come to a major level hospital, the cultures are really negative because of the antibiotic exposure. But in case of this patient, because he didn't take any antibiotics, we were optimistic in the cultures and they were positive for the microorganism. Thank you so much.
Han, any reflections before we turn it over to Priyanka for the teaching points?
Yes, thank you for Dr. Rebecca for the case that up with my knowledge about the endocarditis. I'm sorry that although I try to listen to the learning point of Rebecca, but my listening skills is some limit. So there's some board. Maybe I need to see later on YouTube. And I think the thing I learned from the case is that is the humble event of the endocarditis, which can open my knowledge about this.
Wonderful. Thank you, Han. I agree with both you and Gabrielle and Smitha that this was just a fantastic case. Rebecca, thank you so much for preparing it, period, let alone like this being what sounds like a pretty hot off the press case, which was an absolute blast to get to talk through. I really appreciate the teaching points about Duke's criteria. I feel like it's something that oftentimes in the clinical space, I don't reference or think about or teach on enough. And so this was a great reminder that of their, usually I think of them as like, it's when it is clearly endocarditis, of course Duke's criteria are met, but the other way around, using some of the less common criteria to help work our way towards that ultimate diagnosis was a really great reminder, as using that as sort of a clinical reasoning tool that we all have at our disposal every day. And then just an absolutely fantastic discussion from both you, Gabrielle, and you, Han. It was just such a treat to get to hear you think through this, and certainly made my job feel very, very easy and very, very calming, which is somebody who always gets a little bit nervous discussing a case publicly. It was just very, very nice. And then Smitha, just an absolutely fantastic job thinking through this case. Brilliant teaching, and I cannot thank all of you enough. And again, Rebecca, just the time and effort that goes into preparing these, taking the time out of your morning to present it. We really appreciate it, because this is one that I have learned a lot from, and one that I will be coming back to, I'm sure, to learn more from. So thank you all very much. And Priyanka, let's turn it over to you to bring us home with some of the teaching points.